has a maximum of 40 minutes, to present. After her presentation, we'll have the next presenter that will come in to give a recap of what we just heard. That's about 5 minutes. He will take about 5 minutes to do that. That's the rapporteur. We will summarize what we just heard. Thereafter, we'll throw the floor open for your comments, questions, your contributions, everything. We'll throw the floor open. So that's how we intend to flow for today. After the whole presentation, the president of the association hopefully will address the House. So without wasting much time, because we are sticking strictly to time, I'll invite the presenter, as I said earlier, Dr. Ibekwe. She's a senior resident of the EDM unit of the University of Uyo Teaching Hospital. Dr. Ibekwe, you have the floor.
Okay, thank you, sir. Good evening, teachers, professors, consultants, and colleagues. Welcome to today's presentation. I'm Dr. Norma Ibekwe, Senior Registrar, Endocrinology, University of Uyo Teaching Hospital. The topic for today is autoimmune thyroid disease. And I'll be presenting that using this outline: introduction, epidemiology, types, pathogenesis, clinical features, treatment, prognosis, and conclusion. Introduction. Autoimmune thyroid disease is the most common organ-specific autoimmune disorder, affecting 2 to 5% of the population. It's common in females with a ratio of about 4 to 10:1. It involves a complex interaction of environmental factors in genetically susceptible individuals. Some of these genes are specific for Graves' disease and Hashimoto thyroiditis. Human leukocyte antigen DR3 is present in up to 55% of patients with Graves' disease, while human leukocyte antigen DR3 and DR5 are linked to Hashimoto's thyroiditis. The atrophic and subacute thyroiditis are strongly associated with the human leukocyte antigen B35, while the painless thyroiditis is associated with human leukocyte antigen DR3. Autoimmune thyroid disorder can occur as a component of autoimmune polyglandular syndrome, mostly type 2 and 3. Therefore, patients presenting with one autoimmune disease should be screened for other autoimmune disorders. The prevalence of autoimmune thyroid disease in Africa remains unknown because of underdiagnosis and underreporting. But few available studies show the rate of 1.2% to 9.9%, of which Graves' disease is the commonest. The overall incidence of autoimmune thyroid disorder in Tunisia is 9.9%, and this was noted to have occurred in conjunction with 6.3% of other autoimmune diseases. In Ethiopia, the prevalence of autoimmune thyroid disease is reported to be about 1.2%, while that from Libya is about 3.7%. Hashimoto thyroiditis is highly prevalent in Saudi Arabia, causing up to 43 to 49.76% of thyroid-related issues. Among diabetic patients, thyroid peroxidase positivity was found in 58.6% of patients in Real. Coming to the local studies, a study at Obafemi Awolowo University Teaching Hospital Complex showed that thyroid peroxidase antibody, 38%, is more prevalent than thyroglobulin antibody, which is 24% in thyroid diseases, and is a better marker in detecting autoimmune thyroid dysfunction. For the environmental factors, we have low birth weights, iodine excess, selenium deficiency, use of anovulatories, parity, stress, smoking, radiation, bacterial or viral infections like hepatitis B, retroviruses. We have medications like interferon alpha, lithium, amiodarone, and highly active antiretroviral therapy. They generally reflect the loss of immunological tolerance against antigens from the thyroid gland, with reactive infiltration of T cells and B cells, autoantibody generation, and subsequently the development of clinical manifestations. The lymphocytic infiltration causes tissue damage and alters the function of the thyroid gland, causing the inflammatory reaction, and in some cases, cell lysis. While T lymphocytes are the main cell type infiltrating Hashimoto thyroiditis, B cells predominate in Graves' disease. The thyroid peroxidase antibody and thyroglobulin antibodies are the most common thyroid autoantibodies present in patients with thyroid immune thyroid disorder. The thyroid stimulating hormone receptor antibody is identified in patients with Graves' disease. So components of this autoimmune thyroid disorder include Hashimoto thyroiditis, Graves' disease, painless thyroiditis, and postpartum thyroiditis. For Hashimoto's thyroiditis, also known as chronic autoimmune thyroiditis or chronic lymphocytic thyroiditis, is the most common cause of hypothyroidism in iodine-sufficient areas of the world. For the epidemiology, its prevalence is about 1 in 1,000 people and increases with age, affecting up to 40% of elderly women. It affects more females with a ratio of 18:1. Epidemiology, there is a peak frequency during the fourth decade, and the mean age of presentation is 35 years. An Ethiopian study reported the prevalence of Hashimoto's disease to be 22.8%. Hashimoto's thyroiditis was found in only 1% of thyroid cases, according to a study done in Zaria, while another one done at Aminu Kano Teaching Hospital among first-degree relatives of Graves' disease patients showed 4.6% had positive anti-thyroid peroxidase antibodies and 23% positive for anti-thyroglobulin antibodies. Pathogenesis is characterized by gradual loss of thyroid function due to autoimmune-mediated destruction of the thyroid gland through apoptosis of the thyrocytes. Some theories include 1. Molecular mimicry caused by an immune reaction against an antigen that shares structural similarities with endogenous proteins. 2 is a bystander activation, where a virus reaching the gland or activation of non-specific lymphocytes within the thyroid may cause the release of cytokines, which in turn activates local thyroid-specific T cells, thus favoring an inflammatory reaction. The third one is the thyroid cell expression of human leukocyte antigen. So this expression can be induced by the interferon gamma and other products from the activated T cells or by the viruses directly. They then become non-professional antigen-presenting cells. Fourth is a thyroid cell apoptosis. So cytokine production from antigen-presenting cells and the T helper cells induces the expression of the FAST and the FAST ligands on the thyrocytes, thereby causing self-apoptosis. So clinical manifestation. They have two major clinical forms, the goitrous form and the atrophic type. So there's generally a decrease in the circulating thyroid hormones, causing a decrease in the metabolic rate, an increase in the synthesis of the hyaluronic acid and protoglycans, which leads to the deposition of the glycosaminoglycans. The skin, you could see the xeroderma, thickening of the skin, cold intolerance, loss of the lateral one-third of the eyebrow, the face is swollen, the tongue is sticking, there is hair loss. For the cardiovascular system, we have bradycardia, reduced cardiac output, low voltage on the electrocardiogram. For the musculoskeletal system, we have fatigue, carpal tunnel syndrome, myopathy, arthritis without synovitis. For neuropsychiatry, we have sleepiness, depression, anxiety, memory impairment. For gastrointestinal tract, there's a decreased motility resulting to constipation, dyspepsia, and gastroesophageal reflux. For endocrine, we have oligomenorrhea and menorrhagia. Other findings include hyponatremia, secondary to decreased free water clearance. There's also abnormal lipid values, increased low-density lipoprotein, and apolipoprotein B. So those with the goitrous form may present with compressive symptoms, dyspnea, dysphagia, and dysphonia. Then there's another form of Hashimoto thyroiditis, which is the hashimotoxicosis. This is a temporal hyperthyroid phase, which is caused by an autoimmune destruction of the thyroid cells, releasing excess stored hormones into the bloodstream. So the lab investigations include thyroid stimulating hormone, free T4, thyroid peroxidase antibody, thyroglobulin antibody. So the usual findings include a high thyroid stimulating hormone, a low free T4 levels, and a positive thyroid peroxidase antibody. So patients with high thyroid stimulating hormone, but normal free T4 have a condition known as a subclinical hypothyroidism. For imaging, thyroid gland ultrasound will reveal an enlarged or shrunken gland with heterogeneous ecotexture. Also, an hypoechoic micronodule with variable vascularity. Radioiodine uptake over 24 hours might be normal, reduced, or high, depending on the functional phase of the disease. So in chronic Hashimoto's, the scan might show a patchy heterogeneous or low uptake pattern, reflecting the destruction of the thyroid tissue. So a pictorial representation of the radioactive uptake, the Graves' disease shows a diffuse uptake, while normal tissues show just normal thyroid tissues. For thyroiditis, low or absent uptake, while cold nodules will show a focal area of no uptake, while hot nodule will show a focal area of high uptake with surrounding normal thyroid tissue. Then toxic multinodular goiter will show multifocal areas of radioactive uptake. Then fine needle aspiration shows a marked lymphocytic infiltration and the Hutzel cells. For treatment, the goals of treatment include improvement of symptoms, normalization of thyroid stimulating hormone secretion, and a decrease in the size of the goiter. So these goals are usually achieved with an average replacement dose of 1.6 microgram per kg per day of levothyroxine for adults, then 2.0 to 2.5 microgram per kg per day for pregnant women and those on enzyme inducers. 12.5 to 25 microgram per day for elderly ischemic heart disease. For subclinical hypothyroidism, the decision to treat depends on the serum thyroid stimulating hormone levels. So if the level is greater than 10 international units per mil, the treatment with levothyroxine is indicated. Patients with thyroid stimulating hormone levels that are between 4 to 10 international units per mil, with the presence of goiter, non-specific symptoms of hypothyroidism, or high titers of thyroid peroxidase antibodies should be started on replacement therapy. Levothyroxine should be taken on an empty stomach, 1 to 2 hours before breakfast or 3 to 4 hours after food, and also should not be combined with iron supplements or calcium. For the goitrous patients, surgery is indicated when suspicious on confirmation of malignancy, compressive symptoms, large or progressively enlarging goiter, retrosternal extension, hyperthyroidism, not suitable for other treatments, recurrent cystic or nodular goiter, then patient preference. Prognosis. Over 90% of patients have symptom relief with thyroid hormone replacement therapy, generally excellent with proper treatment. If left untreated, it can lead to heart failure and myxedema coma. While some patients may have temporary hypothyroidism, most will require permanent thyroid hormone replacement. For the follow-up, initial monitoring. When starting or changing levothyroxine dosage, thyroid stimulating hormone levels should be checked every 6 to 10 weeks. Long-term monitoring. Once an effective dose is found, follow-up blood tests are generally required once a year. Monitoring without medication. Individuals not yet on medication should have their thyroid function tested annually. For pregnancy, thyroid hormone needs to be closely managed with testing done every 4 to 8 weeks. Symptom tracking. Patients should report new or worsening symptoms of hypothyroidism or hyperthyroidism. Diet and lifestyle. Avoid excessive iodine, and managing stress can help reduce the severity of symptoms. So the second component, which is the Graves' disease, is characterized by the presence of hyperthyroidism, diffuse goiter, ophthalmopathy, and dermopathy. Epidemiology is the commonest cause of hyperthyroidism, about 8%. The annual incidence of Graves' disease is 20 to 25 per 100,000 in Caucasian population. It's also low among people with African ancestry, most likely due to underreporting. A study in Enugu reported that Graves' disease accounted for 58% of hypothyroidism cases within their sample. A study of pediatric patients showed Graves' disease accounts for roughly 19.7% of thyroid cases in children. Olorin et al. Reported that thyroid toxicosis occurred in 53% of cases of thyroid diseases in southwestern Nigeria. Studies in other parts of Nigeria, such as in Enugu, Kano, have reported a 1.4 to 4% prevalence of Graves' disease in certain patient populations. It affects 10 times more women than men. A peak frequency between the ages of 40 to 60 years have been reported. The concordance rate for Graves' disease between monozygotic twins is 38%. A family history of thyroid disease, especially among maternal relatives, is associated with an increased risk of Graves' disease and a lower age of onset. For pathogenesis, Graves' disease is the result of the presence of circulating thyroid-stimulating hormone receptor antibody that bind and activate the thyroid-stimulating hormone receptor, thus stimulating follicle hypertrophy and hyperplasia, as well as increasing the synthesis of thyroid hormones and fraction of T3 relative to T4. Clinical manifestation could be those secondary to the excess circulating thyroid hormones or those specific to the Graves' disease. So for those specific to Graves' disease, will be goiter, ophthalmopathy, dermopathy, thyroid acropathy. So lab findings include high free T3, free T4, and a low thyroid stimulating hormone levels. So the thyroid stimulating hormone receptor antibody is elevated in greater than 95% of cases, while thyroid peroxidase antibody is in 40 to 70% of cases, and thyroglobulin antibody in 20 to 40% of cases. Thyroid gland ultrasound shows a diffusely enlarged thyroid with thickened isthmus, hypoechogenicity. Color Doppler will show an increased blood flow, the so-called thyroid inferno. Also a smooth, rounded contour without discrete nodules. For the radioiodine uptake, in Graves' disease, the scan typically shows a uniformly distributed, intense uptake throughout the entire gland, distinguishing it from the patchy focal uptake of toxic multinodular goiter, or the low uptake in thyroiditis. For factitious thyrotoxicosis, it shows a very low or zero radioactive uptake. Then for treatment could be medical, radiotherapy, or surgical. So for medical treatments, one is to suppress the hyperthyroid symptoms using beta blockers. Other is to block the thyroid hormone synthesis with antithyroid medication using the propylthiouracil, methimazole, or carbimazole. So for the radioactive iodine therapy, it involves oral administration of radioactive iodine to destroy overactive thyroid cells. So indications include patients that are not tolerating antithyroid medications, or patients in whom surgery is too risky. Also, patients with comorbidity. It's forbidden for pregnant or breastfeeding individuals. Also, men and women should avoid conception for 6 to 12 months after treatment. So side effects include a tender neck or a brief increase in thyroid hormones. The treatment can trigger or worsen Graves' or palmopathy. Another is the surgical approach. Surgical approach when you require a permanent cure, and patients in whom that are not tolerating the antithyroid medications, patients that present with compressive symptoms, and those with worsening eye disease. Another is a thyroid eye disease. Depending on the level of severity, we can prescribe artificial eye drops, selenium supplements, corticosteroids, and also some biologics have been implicated, the teprotumumab. So for prognosis, 45% of patients may experience the relapse of hyperthyroidism, often within 1 year of stopping medications. Surgery provides a rapid and definitive cure and often prevents the worsening of eye disease. So poor prognostic factors include male sex, young age, high antibody levels, smoking, high thyroid hormone levels, large goiter size, severe ophthalmopathy. For follow-up, monitoring thyroid hormone levels every few months during treatment and at longer interval after achieving remission. Monitoring for relapse. Persistently high levels of antibody, thyroid-stimulating hormone receptor antibody, suggests a lower chance of remission and a high relapse risk. Also, managing the thyroid eye disease. So the other component of autoimmune thyroid disorder is a postpartum thyroiditis. It's a destructive thyroiditis induced by an autoimmune mechanism within a year of parturition. It can also occur after spontaneous or induced abortion. It's considered a variant form of Hashimoto thyroiditis. The prevalence ranges from 8 to 11%. A study at the Lagos University Teaching Hospital found that 25% of pregnant women had elevated thyroid peroxidase antibody, which is a major predictor of postpartum thyroiditis. Risk factors include women with positive thyroid peroxidase antibody at the end of the first trimester. They have about 30 to 50% risk. Then patients with a prior history of thyroid dysfunction have about 40% risk. For those with type 1 diabetes mellitus, a family history of thyroid disease, about 20%. So postpartum thyroiditis has been related to human leukocyte antigen B and D. It also occurs in about 1 to 1% to 16.7% of all pregnancies, with an average of about 5 to 8%. So presentation, around 20 to 30% have the characteristic triphasic pattern that lasts up to 12 months. So 1 to 4 months of hyperthyroid phase, 4 to 8 months of hypothyroid phase, and the recovery phase 3 to 6%. So diagnosis shows a positive thyroid peroxidase antibody, thyroid stimulating hormone, and a free T4. For imaging, neck ultrasound will show a mildly enlarged, diffusely hypoechoic and heterogeneous gland, often with decreased vascularity. Non-tender thyroid gland that typically disappears with recovery of thyroid function. Treatments include, for the hyperthyroid phase, beta blockers to manage the heart rate and the tremors. For the hypothyroid phase, levothyroidism, especially if breastfeeding or planning another pregnancy. So for the prognosis, there's a high risk of reoccurrence, about 50 to 70% in subsequent pregnancies. Thus, early thyroid function testing is required in the next pregnancy. Risk factors for permanent hypothyroidism include high antithyroid peroxidase antibody titer, high thyroid stimulating hormone levels during the hypothyroid phase, or having a female child. For symptomatic patients or those with risk factors, thyroid function tests should be conducted 4 to 8 weeks after diagnosis with continued monitoring every 6 to 8 weeks during the symptomatic phases. Due to the risks of permanent hypothyroidism, annual thyroid stimulating hormone testing is recommended even if the thyroid function returns to normal. Re-evaluation of the need for levothyroxine should occur around 12 months postpartum to determine if it can be stopped. So for painless thyroiditis, also known as a subacute lymphocytic thyroiditis, is also characterized by the triphasic pattern. It's considered a variant of Hashimoto thyroiditis and accounts for 1 to 5% of cases of hyperthyroidism. It seems to be more prevalent in areas of high iodine intake. It's also seen in patients following cessation of glucocorticoids and in external radiation of the neck for thyroid lymphoma. Women are affected more commonly than men at the ratio of 4:1. The mean age of presentation is between 30 to 40 years and is associated with a specific human leukocyte antigen, most often DR3, which suggests an inheritance susceptibility. The resulting thyroid inflammation damages thyroid follicles and it activates the proteolysis of the thyroglobulin stored in the colloid. This causes an unregulated release of thyroxine and triiodothyronine into the circulation and results in hyperthyroidism. So once this thyroglobulin is exhausted, hormone synthesis ceases and a state of hypothyroidism develops. As the inflammation subsides, the repaired thyroid follicle resumes normal synthesis of and secretion of thyroid hormone. So the hypothyroid phase is recognized and diagnosed more often compared to the hyperthyroid phase. The thyroid gland is not painful, but it is usually minimally enlarged, sometimes firm in texture upon palpation. For the diagnosis, thyroid function test should be done every 4 to 8 weeks to confirm resolution of hyperthyroidism and detect the development of hypothyroidism. Up to 50% of patients have increased titers of thyroid peroxidase antibody, low radioactive iodine uptake of less than 5% because the thyroid follicles are inflamed and damaged and not overproducing thyroid hormone. For neck ultrasound, a mildly enlarged thyroid gland with diffuse or patchy echotexture, decreased echogenicity. The parenchyma appears heterogeneous due to the lymphocytic infiltration, often showing multiple ill-defined hypoechoic areas, with color Doppler showing low or normal blood flow. So for the treatment, during the hypothyroid phase, beta blockers are given. And in the hypothyroid phase, replacement therapy is levothyroxine. For prognosis, about 8 to 95% of patients experience a full recovery of thyroid function within 12 to 18 months. Approximately 10 to 20% of patients develop permanent hypothyroidism, requiring long-life thyroid hormone replacement. The occurrence is between 5% and 10%. So patients may be at higher risk of developing chronic autoimmune thyroiditis later in life. So for follow-up, during the acute phase, thyroid function tests are recommended every 4 to 8 weeks to monitor the transition from the hypothyroid to the hypothyroid phase. Because of the risk of permanent hypothyroidism, annual thyroid stimulating hormone testing is recommended. If levothyroxine is started for the hypothyroid phase, it is typically continued for 6 to 12 months, after which a trial withdrawal can be attempted to see if function has recovered. So for the differential diagnosis, we have the subacute painful thyroiditis, also known as the Dequipin's thyroiditis. Patients with this normally present with upper respiratory tract infections. So the thyroid gland is also tender, and it can be managed with non-steroidal anti-inflammatory drugs. But in this case, the autoantibodies are absent. For the non-toxic multinodular goiter or the toxic nodular goiter, they present with features of hyperthyroidism, but the autoimmune antibodies are absent. So for thyroid lymphomas, they present with rapidly increasing thyroid glands. So the patient might present with compressive symptoms, and the treatment is usually surgery. And also in this case, the autoantibodies are absent. For drug-induced thyroiditis or factitious thyroiditis, the patients come with hypothyroid symptoms, and once the offending or the agent is withdrawn, the patient goes back to a normal state. So for hypopituitarism, it usually causes a central hypothyroidism, and patient also presents with other deficiencies of pituitary hormones. So in this case, the thyroid stimulating hormone is low, while the antithyroid, while the autoimmune thyroid disease, the thyroid stimulating hormone is elevated. And also, autoantibodies are absent in this case. And also for autoimmune hypophysitis, it can occur with autoimmune thyroid disease. But in this case, it also has essential hypothyroidism and also presence of other pituitary hormone deficiencies. And also MRI can reveal a pituitary mass. For the polyglandular autoimmune syndromes, it can occur in combination with autoimmune thyroid diseases, especially the type 2 and 3. So it's recommended that once a patient comes with an autoimmune disease, it's always good to check for other autoimmune diseases. So this is another table showing a differentiation between subacute thyroiditis and factitious thyroiditis. So for the subacute thyroiditis, the cause is usually inflammation, while for the factitious thyroiditis, is injection of excess thyroid hormones. So subacute thyroiditis is usually painful, while the factitious thyroiditis is painless. Thyroglobulin is elevated in subacute thyroiditis, but is low or undetectable in factitious thyroiditis. The ESR is elevated but normal in factitious thyroiditis. The thyroid size is swollen and tender, but is shrunken or normal in factitious thyroiditis. So like all thyroiditis, the quick shows a triphasic pattern, while the factitious reverses upon stopping injection of the drug. So this is another table differentiating the Hashimoto thyroiditis and Graves' disease. And Hashimoto's also has a triphasic pattern. So depending on when the patient presents, but majorly it comes with a hypothyroid phase, while Graves' disease is usually hypothyroidism. Both of them are immune related. Antibodies are thyroid peroxidase antibodies and thyroglobulin antibody. While for the Graves' disease, it's thyroid stimulating hormone receptor antibody or thyroid stimulating immunoglobulin. So treatments for Hashimoto thyroiditis is usually hormone replacement, levothyroxine, while Graves' disease is antithyroid medication. So recommendations. It is recommended that the following at risk should be screened. Women 50 years and above, persons with other autoimmune diseases like type 1 diabetes mellitus, Addison's disease, vitiligo, pernicious anemia. First degree relative of patients with autoimmune thyroid diseases, a history of previous head or neck irradiation, pregnant women, especially with a family history of autoimmune thyroid disease, neonates of mothers with autoimmune thyroid disease, to rule out neonatal or infant hypo or hyperthyroidism, which can negatively impact on growth and development. So in conclusion, autoimmune thyroid disease is the most common organ-specific autoimmune disorder, resulting in dysfunction of the thyroid gland. It is linked to other autoimmune diseases and requires long-term management. It can cause significant morbidity if untreated. Thus, early diagnosis, treatment, monitoring are key to preventing complications. Thank you for listening. These are my references.
Thank you. Thank you very much, Dr. Ibekwe, for that excellent presentation. It was quite detailed, I must confess. Thank you very much. As I said earlier, after her presentation, the next now will be a brief recap of what we've just heard. The rapporteur will come in just to summarize what we've just heard before we throw the floor open for our comments and contributions. So next is Dr. Asupong Esor to give us a recap of what you just heard. Dr. Esor.
Okay, good evening, teachers, professors, the South Zonal Chairman, and other people present. My name is Asupong Esor. I'll be the rapporteur for this evening. So the presenter has just completed about a 30 to 35 minutes presentation of autoimmune thyroiditis. And she started her presentation with an introduction of autoimmune thyroiditis as a common organ-specific autoimmune disorder. She reiterated that females are more affected in a ratio of 4 to 10 to 1. That's a female to male ratio. And autoimmune thyroiditis was noted to be a component of autoimmune polyglandular syndrome. Epidemiology figures were rolled out to include African epidemiology studies, values, which showed increased prevalence in some parts of the world and parts of Africa, but more specifically, increased prevalence was noted in Saudi Arabia. The risk factors such as low birth weight, iodine excess, use of antiretroviral therapy were noted as some of the risk factors that were associated with autoimmune thyroid disorder. And the role of T cells and B cells in the pathophysiologic process was also reiterated by the presenter. She went ahead to list components of autoimmune thyroiditis to include Hashimoto's thyroiditis, Graves' disease, postpartum thyroiditis, and subacute lymphocytic thyroiditis, also known as the painless thyroiditis. On Hashimoto's thyroiditis, it was said to be the most common amongst these and was noted to peak at the fourth decade of life with a mean age of occurrence at 35 years. And it's said to involve autoimmune destruction of the thyroid through some proposed mechanisms that include molecular mimicry, cytokine activity, and viral activity, amongst others. It manifests clinically, as the presenter showed us, as atrophic manifestation, a goitrous type, and a form that is known as hashitoxicosis. The specific laboratory findings in Hashimoto's thyroiditis were highlighted alongside its radiological features, and this was discussed in detail by the presenter. Modalities for treatment with levothyroxine were also highlighted depending on the phase in which you find it, and indications for surgery, especially in the goitrous type, was also discussed by the presenter. She went further to talk about Graves' disease and said that it manifests majorly as hyperthyroidism, ophthalmopathy, and a diffuse goiter. And the prevalence of Graves, especially with local studies, was discussed by the presenter. She noted the peak age of occurrence of Graves to be about 40 to 60 years of age, and increased thyroid receptor antibodies' role in activating thyroid stimulating hormone receptors as a core of the pathophysiological process was also discussed by the presenter. Specific laboratory findings alongside its radiological findings were discussed, and the role of radioiodine uptake was also highlighted, and the uptake was noted to be a uniformly distributed uptake. Treatment modalities in Graves' disease were noted to be control of the hyperthyroid symptoms, to block thyroid hormone production or synthesis, and this was by the use of antithyroid medications, and more specifically, radioablative therapy was discussed. The role of surgery was also brought to the fore by the presenter and was thought to be the most definitive modality of treatment with a 99% success rate. TRAB was highlighted to be used for monitoring for relapse cases, for tendency for relapse in Graves' disease. The presenter also went ahead to discuss postpartum thyroiditis and said it was a destructive thyroiditis, and the role of thyroid peroxidase antibodies being a major predictor in postpartum thyroiditis was also highlighted. Postpartum thyroiditis was noted to be linked to HLA, B, and D, and is said to occur in about 5 to 8% of pregnancies. It exhibits a triphasic pattern that specifically shows a hyperthyroid phase or a hypothyroid phase and a recovery phase. And the treatment for postpartum thyroiditis was highlighted to depend on the phase at index finding of the patient. And the role of monitoring was also emphasized by the presenter. The presenter went ahead to discuss painless thyroiditis and said that it is a HLA DR3 associated condition with the mean age of presentation being 30 to 40 years. And it's important to note that she emphasized the triphasic pattern also being found in painless thyroiditis. Histological findings of lymphocytic infiltration is a hallmark of this condition, and this was highlighted by the presenter. And the tendency to develop Hashimoto's thyroiditis later in life was noted in this condition. The presenter did well to go further to make tabular distinctions between various types of thyroiditis using specific parameters, and these were discussed in details. Following these, recommendations were made for screening, which include 50 years and above women should be screened for autoimmune thyroid conditions. Patients who were noted to have other autoimmune conditions are recommended for screening for autoimmune thyroid disorders. Then the relatives of first-degree relatives. First-degree relatives of those with autoimmune thyroid conditions are also recommended for screening for thyroid autoimmune disorders. And she concluded by highlighting the need for a high index of suspicion, early diagnosis to be made, and early institution of treatment for autoimmune thyroid disorders. Thank you very much. And these were the highlights of the presentation by Dr. Ibekwe. Thank you.
All right, excellent, excellent, excellent. Thank you, Dr. Esau, for that recap. So many talking points, if you ask me. Maybe I'll start by just mentioning some of the things I think we should be considering, like, for instance, how frequently do we really screen our patients for autoantibodies? Do we just look at the patient and say, oh, this is Graves' disease, without no evidence of no autoantibodies to back it up, or this is Hashimoto thyroiditis? How frequently do we screen our patients? Another talking point should be how, for instance, pregnant women. Should we be screening our pregnant women for autoimmune thyroid disease, considering the effect this can have on the fetus and the infant, the newborn? These are just some of the talking points. So without taking much time, I think it's now time for questions, contributions, and your comments. So now at this point, I'll throw the floor open. If you have a question or your contribution or a comment to make, please, you indicate by raising your hand, or you can use the comment, the chat box. But I think it's faster by just raising your hand. If I see your hand, I'll recognize you, and we'll take it from there. So if you have your comment, your contribution, or a question, let me just see your hand. Or better still, you can just unmute yourself and then go ahead. You can just unmute yourself and go ahead, so that will not take much time. After this question and answer session, the president of the association, Prof. Oloko, will address us. Thereafter, we'll call it a day. So I'm still waiting for your questions, waiting for your comments, your contributions. So many points, if you ask me. Very interesting topic. If you actually took time to listen attentively, you agree with me that there are so many talking points. So the floor is either you indicate hand or you unmute yourself. I'm not seeing maybe okay. Yes, Prof. Nachuku, please. You have the floor, ma. Yeah. Prof. Nachuku, you have the floor, ma.
Yeah, good evening, everyone. I hope you can hear me.
Good evening.
Can you hear me?
We can hear you, ma. We can hear you, ma.
Okay. Yeah, I just want to appreciate.
Yes, ma. We can hear you.
I want to appreciate the South Zone for coming alive again, and specifically to appreciate the presenter and Dr. Esau for this wonderful evening, presentation. Yeah, we all know that thyroid diseases are no more rare. They are not rare at all. And the centers where we run, specific endocrine clinic, you will know that it is the highest, endocrine disorder in that clinic. Diabetes has its own clinic, but in the endocrine clinics, you will find out that thyroid disorders are on the, they are on the increase, and they are ranking highest, in prevalence. Now, we also know that we have different models, just like we have all heard. You know, we see our patients at different phases. And you should bear in mind that most of the cases of malaria and typhoid, they may just mimic, you know, thyroid disorders at different phases. So it takes, you know, your acumen, your clinical acumen to screen these patients and identify what is actually wrong. You will see that thyroid diseases, I mean, we don't just talk of Graves alone. It's not about Graves alone. We have varieties of them. Also, I'm happy the presenters went, you know, to town to talk of what we see in the pregnant women. You know, they are there with us, but you will not know until you have screened. You can't give what you don't have. So I want to encourage all of us to please begin to screen more, begin to look out for these disorders. They are with us so that we don't keep overlooking what we can handle. If you do not check, you will not identify. So this is an eye-opener. You know, it's not about Graves. You see all the symptoms and you say, oh, they are there. The hypothyroid disorders, before they go into the euthyroid phase, when you catch them, they are part of the syndromes of these thyroid disorders. So I want to encourage all of us to do what we have learned, to practice. Let's not just assimilate and go to bed. Please go to town and screen patients, and you will be doing ourselves a lot of good. Thank you so very much, South Zone, for this beautiful evening. Thank you, everyone.
Well, thank you, Ma. Thank you, Prof. Thank you, Prof. Thank you for that excellent contribution. Yes, I think the highlight of her comments is screening. We learned all these things as specialists. Let's not throw it away. You don't just look at a patient or assume, oh, this is Graves. No, it cannot be Graves. If you've not, you don't back up what you've done, your diagnosis with the presence of the autoantibodies. Okay, it cannot be Graves. That diagnosis is incomplete if you've not done the autoantibodies. The same thing with Hashimoto thyroiditis. Oh, this hypothyroidism, okay, is the commonest type is Hashimoto thyroiditis, but you must back it up. Yes, you must back it up with by screening for the presence or absence of autoantibodies. It's something we should do. And I'm happy Prof mentioned the pregnant women. Yes, it's something, one area we have ignored. I think we should start looking at it. Pregnant women, history of autoimmune thyroid disease should be screened. Should be screened. That's part of the recommendation from this presentation. Should be screened for thyroid and autoimmune thyroid disease because we know the effect this can have on the fetus and the infant, the newborn infant. So I think one of the very, very important take-home point here is please, let's not shy away from screening our patients. If we suspect the patient has autoimmune thyroid disease, the diagnosis is incomplete if on the thyroid for that contribution. Please, the floor is still open. Thank you. The floor is still open. Okay, I think I've not seen any other hand. So in the absence of any other hand, and I think at this point we'll invite the president of the association, Prof. Uloko, I'm sure he's on the call. I've seen his name here. Invite him to take the floor and just address the House. Prof. Uloko, you have the floor, please.
Thank you very much, Dr. Onung, chairman of the South-South Zone for our dear association, EMSON. Good evening, distinguished colleagues and seniors It is my pleasure to be part of this meeting this evening. I joined the meeting right from the outset. I must congratulate first the speaker, Dr. Ibekwe, for doing justice to the topic. And I will continue to commend the South-South Zone for taking the bull by the horn and keeping to schedule. Each time we bring out the schedule of our endocrine lecture series, the South-South Zone from the past year or so has been consistent in keeping up to date and delivering excellent lectures. So we must thank the zone for keeping the spirit alive. This is one of the main agenda of our administration when we were sworn in and during the campaigns, and I'm happy that we are living up to it. I also want to say that this month, the month of May, is a thyroid awareness month, and we will be seeing a number of presentations and talks on thyroid diseases. I think the World Thyroid Day is somewhere around 22, 23, thereabout. I will charge us to please do thyroid awareness in our different institutions and communities, that the community be aware of the seriousness and the increasing incidence and prevalence of thyroid diseases in Nigeria. One of the main issues with thyroid disorders in Nigeria is the fact that there are myths, there are false beliefs around thyroid disorders, and then there is late presentation. Quite often, most of our patients present rather too late. And by that time, they must have begun to suffer one or two complications of thyroid diseases. And so let's look forward to that. Let me also remind us that on the 17th of May, 2024, our immediate past president went to be with the Lord. And so it was such a painful and devastating experience for us as a society. We miss her dearly. This 17th of May 2026, she would have been 2 years since she went to be with the Lord. In commemoration of this day, the family, in collaboration with EMSON, will be celebrating her memorial, and there will be a memorial activity in Benin, to which, by the grace of God, I am going to be physically present and to deliver the maiden Professor Teresa Ayanwa Irige Memorial Lecture. And the choice of discussion is going to center around thyroid disorders. So I am sure that in the course of the preparation, the announcement will be made on how to join online for those that will not be able to make it to Benin. And since this is happening in the South-South Zone, and South-South Zone is doing this talk now, I want to encourage us to pay her this one more respect of attending this very solemn event where we wish to honor her life and times and the good times we had with her and the impact she made in EMSON and EGM in Nigeria. Having said that, I just want to thank everybody for being part of this laudable objective. There is also the renewed formation of study groups. And these study groups have been painstakingly put together so that we will reinvigorate the areas of research and academic discourse as it concerns EDM related issues in Nigeria. Let's not also forget that there is an ongoing effort at presenting the thyroid guidelines, clinical practice guideline for thyroid disorders in Nigeria, the first of its kind. We're working around the clock to see that we achieve that, being the second after our well-celebrated diabetes mellitus clinical practice guideline that was launched during the EMSON of 2025 in Lagos. Lastly, let's not forget that this year, 2026, we are going to be hosting the annual general meeting and scientific conference in the federal capital city, Abuja. The organizing committee is working around the clock to seeing that we have a befitting and elaborate meeting this time around. Announcements have been out. We have been seeing the flyers of the first announcement. Second announcement will follow. I want to encourage us and challenge us to please prepare to be actively involved, as we have always been, in this very wonderful meeting that is being put up by the organizing committee. Let's send in our abstracts, because a scientific conference is no conference if there are no abstracts to present and to discuss. Let's begin to keep our calendars updated as we prepare. All routes leads to Abuja come September by the grace of God. I'm aware that there are a few other international meetings here and there. The International Society of Endocrine, International Congress of Endocrinology is taking place in Japan, sometimes in August this year. It will be encouraging if we have members that can attend that meeting and represent us. Please, should any member be at the meeting, try to emphasize your presence and let us know so that we can celebrate you as our worthy ambassadors. With that said, I would like to thank all of us for working together as one team, one family, in advancing the cause of EMSON, EDM practice in Nigeria. Continue to do the best that you are known for, and may God continue to guide all of us. Thank you so very much, and good evening.
Thank you so much, our able President, Prof. Uloko, for that address. And let me also add that may the soul of our immediate past president continue to rest in peace. Thank you all. Thank the presenter, Dr. Ibekwe. Thank you very much. Dr. Esau, thank you very much. Thank you, everyone, for finding time to join this CME lecture. And I'm sure you've all benefited from this presentation. Remember, thyroid disease, endocrinology is not all about diabetes. Thyroid disorders are here with us, especially the autoimmune thyroid disorders. Thank you once again, and good evening. God bless you.
Okay. Bye-bye. Bye, everybody.
Yeah, good evening. Thank you, Prof. Thank you. Bye, everybody.
Bye,
Bye.
sir.
Thank
Bye.
you.
Bye-bye.
Yeah,
Bye.
Prof. Bye. Thank you so much. Thank you, Prof.
Bye, Dr. Monk.
Yeah, thank you so much, Prof. Thank you for joining.
Thank you. Good to hear your voice again.
Yes, ma. Yes, ma.
Yeah.
How's the family? How's the family, ma?
We are good. We are good. We are good.
Okay. All right.
Yeah.
All right, ma.
Yeah.
Take
All
care.
right.
Take care, ma.
Thank you.
All right.
Thank
Ma.
you so much. Appreciate it.
All right. Thank you. All right. Thank you, ma.
Yeah.
I saw. Okay, bye bye now.